is not just to heal, but to innovate and elevate the very foundation of healthcare. In this era of rapid technological advancement, we stand at the crossroads of possibility. Let us unite to leverage cutting edge technologies, fostering a healthcare system that prioritizes accessibility, affordability, and above all, empathy. Together, let us champion a future where patient centric care is not just a phrase, but a fundamental principle. The collaboration of healthcare professionals, researchers, policymakers will forge a system that not only heals the sick but actively promotes wellness. Here comes our session number 6, Reimagining Healthcare Delivery. And I promise you, this is going to be one of the best sessions because we have a lined up of presentations which you would have never heard before. I would now want to invite Dr. Oommen John, Country Lead Health Systems Design, Data and Insights, Bill and Melinda Gates Foundation, whose leadership and expertise will undoubtedly guide us through an enriching and insightful conference. I welcome you, sir. Please allow him with a huge round of applause.
Good morning, good afternoon. You with me? When we say good morning, we respond, right? This is a responsive session. Oh, good afternoon. So I guess I'm between, or we are between you and your lunch. So here is a fundamental question. If I need to move from point A to point B, today I have a number of technology-enabled solutions, and because of which I get a lot of instant gratification and also service obligation. I want food, the same happens. I want groceries, same happens. But if I need to access healthcare, I have to really be patient because that is how we treat patients. You need a lot of patience to be really a patient because we have not reimagined how health services delivery can be improved using technological advances and innovations. I want to introduce the session by saying we have a panel of experts who are going to be sharing with us how we can really reimagine health services delivery. Today, we actually deliver sick care through institutions that are fragmented with specialists who are very, very specialized in very, very small aspects of an organ or its function, or rather its dysfunction. But is that how we are supposed to be approaching health and wellness? Are there newer mechanisms, newer approaches that one could apply? Okay, imagine what happened during COVID. Did all of the sectors come together? When somebody was having symptoms, he or she could call up a place, and then someone would help triage, a test would be done. When the test results are available, someone could actually ensure that the necessary care, and if they needed hospitalized care, a hospital bed could be found, because there was a scarcity and health systems were overwhelmed, and therefore we used technology and innovations to bridge those. COVID has come and gone, and we've forgotten that all of those technologies and innovations that we actually used for delivering health services, and we've packed up those innovations, and we're back to square one. We've gone back to the routine of needing to take appointments, go stand in a queue, and wait patiently for the doctor to arrive. But can we turn the paradigm around as we are reimagining the health services delivery? What if I were to engage in a little bit of imagination? What if there is a lady who is 80 years old, she is illiterate, and does not own a smartphone and lives in a remote part of India where even internet is very patchy? Does she require to be given the same level of care that you and I have access to sitting in the heart of Delhi? Can technology allow us to do that? In this scenario, okay, I'm not talking about she needing to have, to be literate, that she owns a smartphone or she has to get onto a smartphone to, but can we deliver care for this particular lady who is 80-year-old, living in remote part, does not have like the good internet yet, and she may not be very fluent in English or even Hindi? Can we assure health services delivery for her? Are there tools today? Question: are there tools today that will help us connect her to health services delivery? Yes or no? 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 What about a toll-free number? If there is a toll-free number, okay, she borrows a phone and she makes a call into that toll-free number, and then someone on the other end asks us, what is your age? Where do you live? Okay? And then what are you calling in for? So I am having a headache, I am having blurred vision, and I am having slight weakness. Okay? You ask these questions, and the end of that person, this could be a 10th pass or fail, but we have trained this person to be able to ask these questions, and the person is aided by an adaptive question engineer, an engine. Okay, so when you put headache and this blurring and weakness on one side, it props up and says that it could be a stroke. Next step, so the system guides that this person is probably having a stroke, and here is the nearest ambulance that is available. Okay, can we move the ambulance to her wherever she is and have her move to a place where stroke care can be provided? Today, who decides where an emergency care goes? Do you know? In our country, when somebody is having a stroke, who decides where that person should get care? Any guesses? The ambulance driver decides where that care. That if it is a stroke, he might actually take her to a place that is giving a kickback for an abdominal surgery. That is how care is delivered. It's plain and simple, unethical. But can technology solve for this? Absolutely. So let's imagine that the ambulance has reached there, and the ambulance driver is also trained in being able to assess quickly assess, and then over a video call is able to connect to the coordinating center and give the vitals or whatever. And then quickly we are able to move her to a place that where recombinant RTPS can be given. All of this happening within the golden hour. Is it possible? It's very much possible. Are we talking about enterprise architecture? No, we're talking about a simple call center. Okay? All that we need is a person who is available there with an adaptive question engine there, and we have, with ABDM, we have the health facilities registries. It's still emerging, but when health facility registries are there, we would be able to know where a stroke specialist is available and where stroke beds are available, where RTPS is available. So can we connect these dots together and reimagine health services delivery in a new manner? And let's assume this lady is actually had her thrombolysis there, and then after 7 days, she's been discharged back home, and when she goes back home, her health worker in her locality is actually told that such a person had a stroke, has undergone thrombolysis, and she needs to be regularly monitored for blood pressure. A simple SMS to that frontline healthcare worker through our call center could ensure continuing care, and we can have the loop closed. So let's imagine that 1 month later, the same lady has gone back for a follow-up, prompted by the frontline healthcare worker, And in the PHC, there is no medicines for the continuity. So let's assume that she was prescribed antihypertensive, which is not available in the PHC. But can we have it delivered to her from some other place? Can we again use leverage technology for that? Is it possible? India Post is there. If with the prescription, and if the medicine is already available, it is given. If it is not available, we try and give it from a pharmacy that is in 5 to 10 kilometer vicinity. And beyond that, within 24 hours, can we assure that the medicine actually reaches the person at her home as and when necessary? In India, a bulk of the out-of-pocket cost is because of diagnostic delays and because of the time that is lost in the friction in patient journey. Can technology solve for the friction in patient journey? We think definitely it can. And we from the Bill and Melinda Gates Foundation are experimenting with a couple of state health authorities in trying to solve for this through these call centers. So we are working with existing call centers, providing training for the call center staff, providing them this adaptive question engine, and then trying and testing whether this is working or not. So I'm just leaving this to your imagination. Many of you in this room are probably IT students and using data for insights. Many of you might be wanting to be starting up new solutions in the area of improvising health service delivery. Let your imaginations go wild, and let's hear our panel of experts and what their experiences have been in this area. Thank you.
I now request Dr. Priyanka Bajaj, Manager, Health and Innovation, Impact Lab Path, to come and start with her presentation and enlighten us all. Please put your hands together for our presenters. They are here to help you out with this session, so be grateful.
Good afternoon, everyone. I really like the word enlighten. I hope I can at least prime you all to a different kind of area that I work in. While the presentation is opening up, I won't take much time. I've been given a guidance on taking very little time on the presentation and keep it more for the interactions. The reason why I have some slides is to give you a new perspective on reimagining healthcare delivery, clinical validation being one aspect of the new technologies that come in, but what goes beyond clinical validation, how you see a technology leapfrogging from a prototype to a market-ready solution to a solution which fulfills the need of the health systems. So if we can start with the first slide, please. The next one. Can I do it from the laptop here? Thank you. Sure. So I represent an organization which some of you may have heard of. It's called PATH. We are an international not-for-profit based out of Seattle. We work in global public health, and with our country portfolio, so with our country portfolios, we work in devices, diagnostics, vaccines, data, and health system strengthening. Overall, if you look at this snapshot, it shows our work across 70 plus countries, working for 150 plus million lives. Some of the things that young students like you may have heard of are the vaccine vial monitors that very proudly has come out of one of our interventions. Then fortified rice with vitamin A, folic acid, B12, and then other solutions, some of which I'll speak here in the subsequent slide decks. This is just to give an idea of how we work in the South Asian region, India country program being active in more than 20 states, and the others like Nepal, Bangladesh, Sri Lanka, and Myanmar, hoping to solve some of the healthcare gaps through newer technologies. This is also one of the programs. The reason I am here because I lead this program. It's called Impact Lab. And what we try to do is, support health technology innovations that can bridge gaps in healthcare, otherwise left through the conventional means of how they were being addressed so far. So if you look at typical product cycle, I believe some of you are engineers, solution developers, you would understand it from your first-hand experience. You start with an idea, you do research, make a prototype, then you validate it, and that's where comes the role of clinical validation. That's where also comes the role of operational validation. Now, what operational validation is how the solution performs in the real-world settings. So something which may be working fantastically well with high sensitivity, specificity in a controlled lab environment, you may see that it doesn't perform as well when it is taken to a field with high temperature, humidity, technicians which are not as trained as a tertiary care hospitals. So those are also the things that we need to consider when we are bringing innovations for newer models of healthcare delivery. Then again, an important role of regulations and approvals to ensure patient safety, efficacy of the new technology, and the quality of the product that is coming in. Connecting through the right market access channels and the public health systems, where eventually the adoption happens, because the cycle of success of the enterprise and success of the public health system goes hand in hand. These are some of the impact numbers of our performance, which we can skip for now. It's a snapshot of the first cohort of technologies that were part of our support portfolio. Very sector agnostic in the sense that you won't see a disease area priority in this, but these are all medical devices and in vitro diagnostics. Just to give you an idea, something like a smart scope from Periwinkle Technology is a smart tool which can take photographs of the cervical cavity and then uses AI on top of that to interpret images for precancerous and presumptive cancerous lesions, so that the referrals can be made. Obgyn sitting remotely can visualize those images. Teleconsultations can be made. The idea is to improve access to the last mile. Again, moving forward, we thought, what is it that can really make a difference to a country setting like India, to the low middle income countries group that we say, which have their own resource constraints. And one thing probably I think we all would agree is access to comprehensive primary health care, which is the first point of connect between the care seeker and caregiver. And to meet this end, while there is an expanded package of delivery for primary healthcare, there are priorities for primary healthcare, including service, healthcare workforce, and all the other things. We also see that the provisions for essential medicines and health technologies is one of the priority recommendations for improving primary healthcare, for achieving the sustainable development goals, and the overall goal of universal health coverage, which very coincidentally is being celebrated this week as UHC Day. So this is a challenge that we rolled out for the wider community at the global level, and we were looking at solutions which could improve primary healthcare through innovative medical technologies, digital health tools, and supply chain solutions. And 17 winners emerged out of it. These range right from something like a smart stethoscope, I'll come to it in the next few slides, to something which could enable ultrasound at the last mile. And because we're talking about global solutions, we would, for the time being, leave just a very specific regulatory requirement aspects for India or for other countries, very contextual in their sense. Cold chain solutions with real-time monitoring of temperature, location, so that blood products, vaccines reach how they should reach to the last mile. Very quickly, some of these innovative technologies, and when I showed these to one of our external global donors, not the Gates Foundation, the answer that we got was, we want technologies which can reach to the last mile. These look very sophisticated. And to that, our answer was, these are at the last mile. We are having a district model demonstration project in Satara district in Maharashtra. At rural PHCs, these technologies have been deployed. What they're doing is, say, the first one, which is from a company called Niramai, it does thermal imaging and applies artificial intelligence to it to capture markers of breast cancer non-invasively, radiation-free. And then it improves the risk scoring and it enables referrals right at the first point of entry at the primary healthcare. Something like an AI steth, it's a smart stethoscope which converts sound to graphical data, then AI can interpret it and tells for cardiovascular the abnormalities in that. Alveofit is bringing spirometry to the last mile in a very affordable manner. I remember meeting the innovator for the first time, and their pitch was, spirometry is air, why is it so expensive? And this is not that expensive. Plus, it connects with the digital ecosystem, so data storage and reference, and access for the clinician to look at it in real time becomes feasible. And then smart scope that I already described earlier. Then these are some of the other technologies on maternal, newborn, and child health. We have recently started an operational validation of 2 of the non-invasive hemoglobinometer just to see their performance, how they're doing it on the field. And if that is working, then it can really improve access to screening. Screening sometimes becomes very important, sometimes more important than diagnosis, because when you can screen the masses, you can really bring down that funnel and know where the care is needed and give them that quality care. Other things like fetal heart monitoring, point of care detection of preeclampsia, all part of it. If we want, we can discuss it offline as well after the presentation. Since I said clinical validation and beyond, there are a few other case examples. Just, have that broader perspective, your young minds think about it. If some of you want to be innovators, then innovation is also science, but it is also business, it is also policy, it is also market access. So something which we are testing now is a G6PD diagnostic device. We are doing a clinical performance evaluation and doing it at a multi-country level with parameters which could also help with WHO pre-qualification. This is the figure on the right is a portable MRI machine, which is very novel in the sense that I don't know if any one of you have heard about MRI being portable. The one that came from India very recently is a huge one. It's not a low field, but this is a low field, and it is meant for pediatric head scans and improving access to rural areas, to low resource settings where no other solution may be available at the time. Then self-testing again, we have all seen during COVID time, self-testing came big time. But to make it a larger case beyond a pandemic-like situation and extending it to other diseases, we need to have data on the feasibility, how well the users are adopting it, and how this may integrate with the program along with other consideration, barriers, limitation, and we'd like to believe with other enablers. Now, just to compile this all together, and one case study that can show how process, product, and partnership innovations can really make a difference is our work during the COVID time, where we worked with the state government of Maharashtra, Punjab, Meghalaya, and Haryana. In terms of process innovations, we optimized the capacity of labs. We brought in new laboratory management information systems. We tested differential testing algorithm like dual swab, other things. In terms of product innovations, some of you may have heard about the Abbott ID now, which is a point-of-care real-time PCR device, and that was tested as soon as it was introduced at that time. And partnership, of course, we need multi-sectoral collaboration to really make a change. The impact numbers on COVID testing, of course, are huge and humongous and outside the scope of us comprehending it. But to show that, something like a new startup, cloud pathology, could make the backlog so clear by automating data capture, filling in the SRF ID forms that ICMR needed with all COVID testing samples. Something like a dual swab, which could use antigen testing, and then that swab sample could then be, if positive, could be referred for PCR, and if negative but symptomatic, is not lost at that point. And then genome sequencing labs were also strengthened through introduction of Oxford Nanopore point-of-care sequencing device, and certain microsite testing laboratories were set up. So thank you for your time, and yeah.
Thank you so much, ma'am, for this insightful, knowledgeable session. We would move forward with Dr. Sapan Kumar, MD Respiratory Medicine, FCCP, FAPSR. I request him to be on stage, please. Kindly welcome him with a huge round of applause. We can all show a little more energy. I think lunch is just a few minutes away. We can show a little more energy, please.
So hi everyone, I am Dr. Sapan Kumar. So I'll be speaking about this topic. So after completing my setting up the background, so after completing my post-graduation from one of the biggest colleges in the country, I started working in place called Chhattisgarh and Orissa. So Mungeli, Noapada and Dhamtri. So coincidentally, you will be hearing both of these places for some of the not so happening things like children being sold for money because parents are so poor, or women delivering on the cot, and this is river crossing the road. So these are the type of places that we have been working. Dr. Oommen will be quite familiar because he's also from CMC Ludhiana. So this is one of the hospital. This is not anybody's home. This is a hospital in Khariyar. So this is actually what I'm trying to say is the ground reality of majority of India is, and what you see in Delhi is just a small picture. And these are the beautiful people of local tribes. And this is what I believe there's a triad. There's area of Naxalism and the lowest literacy rate and the highest poverty. All these things eventually leading to very high mortality rate among the women and in children also. So these are the indirect health indicators as to how the country is doing. As you can see, it's not only Orissa and Chhattisgarh, but most of the North India lies in the same plane. Regarding India, the health expenditure percentage GDP has over the years increased to up to 2.1%, but still it is less as compared to most of the other countries. For US, it is about 17%. That's according to one of the speakers, it is more than India's GDP. So starting with the story, one of my colleagues' father, he was brought to casualty. He had a fall and he was drenched in blood. So when he was brought to casualty, he was unconscious. So when somebody is unconscious, we put a tube in the airway. That's called intubation. So he was requiring intubation. By the time I was called, it was little bit late, about half an hour late. And but eventually we were able to intubate him, put a tube in the airway, and we were able to rescue him. He survived the day, but then there was some amount of hypoxic brain damage because of lack of oxygen. So when I was looking into as to what could have been done to save him, one of the solution that is offered for new users who are in the new doctors who are in casualty, they could use something called a video laryngoscope. But the commercial video laryngoscope, they cost about 1 to 20 lakh rupees. So definitely that is out of our reach of our hospital. So I came up with the question as to how such a costly device can be brought to resource-limited settings such as ours. So I came up with this device. This is the most low-cost video laryngoscope device which was made for resource-limited setting. It was presented in an international conference called CHEST. And this is the paper. And this is the device as it is functioning. I'm unable to skip the video, so it will take some more time. Anyway, so this is the study that was compared with the conventional video laryngoscope. Conventional laryngoscope. And then came the COVID, and we had very limited PPEs, hand rubs. We had limited finances and limited staffing. And I was the only chest physician in the entire district. So, and not only in our setup, it was actually the event that was happening globally. So the global healthcare backbone was broken, and that led to me into developing low-cost solutions for resource-limiting settings like ours. So that time I was in a place called Mungeli, which was famous for once in a time for world's first mobile eye cam clinic cataract surgery was done. And this hospital is about 125-year-old, and it is one of the oldest in the country. So it was a perfect storm that had taken the entire globe's healthcare. And the challenge that I felt was to provide best for our patients and also to keep our staffs safe and to make it affordable and also to rapidly evolve our treatment with the changing guidelines. So I had come up so Mungali, as you can, it was basically a peripherally located center, and we received a lot of sick patients, and those sick patients could not be referred anywhere, and also because the big hospitals which are already available were already going in full capacity. So I came up with the concept of comprehensive COVID care. That was initiative to strengthen already existing resources to deliver best care that is possible during the time of pandemic. That led to development of low-cost solution, and this we found to be useful. This is a roadmap, a mind map of how the concept is. It involves all the aspects of healthcare, including pre-hospital care, hospital care, post-hospital care, rehabilitation, everything. And this was a unique, novel concept that was also taken by USAID and RICE. And it's a unique concept because this could even be taken to any other future pandemics. So this was this particular model helped us to decrease the morbidity and mortality of the people and relieve stress on the already overstretched healthcare system. Again, another problem that we faced during COVID is a lot of COVID patients landed up on ventilator. So this is how a ventilator looks like. But one of the biggest problem is because patients were involving in prolonged ventilation because of secretion and mucus, that these particular tube used to get blocked. And as you know, in peripheries, the doctors and other nurses or healthcare workers or even the equipment, they're not up to the mark. And changing the tube every time poses a health risk to the healthcare worker because of aerosolization. A lot of small droplets come, and that will increase the risk of healthcare worker to get COVID. So this was the question, that how can we detect endotracheal tube block without increasing the risk of COVID to the healthcare worker. So I came up with this particular solution. It's called, so this was a novel concept which I had also presented in an international conference called CHEST. That time it was in Bologna. And this is how the normal endotracheal tube looks like, and this is how the picture of a blocked endotracheal tube looks like. Some of the problem, this is a partial occlusion of the left main bronchus. This cannot be detected in any way by conventional method. So this was a novel method that we have devised, and it was appreciated in the CHESS conference. So again, another very basic problem that we dealt was medical teaching. Because of COVID, the students were unable to go to the patient's bedside. So how we will teach such patients during the time of COVID? So, and also with the shift and drift in medical education to provide better competencies and to improve patient safety. NMC and INC, these are the two medical council for the medical and the nursing. Both have made it mandatory for the colleges to have a simulation lab or a skill lab. And also, as the government is planning to open medical colleges in each and every district of the country. So the question is how, with the limited finances, both from the government side and the private sector side, how is it possible to establish a skill lab in far end corner of the country? So before I go further into the topic as to what is a simulation or a skill lab is. So basically anything that can teach a correct technique without going into the real event is basically a simulation. I'm talking about medical simulation. So suppose I'm talking about, say, suturing. So suturing can be done directly on patient. At the same time, we can buy a commercial pad that will cost about 5,000 rupees, or we can use something like a virtual reality or a augmented reality solutions that will cost in couple of lakh rupees, or a very simple low-cost suturing model that will cost maybe less than 100 rupees. So the problem with the current simulation model is that they are high cost, high maintenance, and there is a very interesting phenomena that you will see in medical colleges. I call it coffin in, coffin out. Basically what happens during the inspection time, suddenly from the cabinet, the high-end mannequins will come out. They will be put on the show. They'll be shown to, sir is already laughing because he'll be knowing as to what the ground reality is. And as soon as the inspection is over, it will be put back into the box and put it back into the cabinets. So that's how the reality of medical simulation in India is. And also we have about 100 to 150 medical students. And it's not only the medical student, we have nursing students, paramedical and staff. And everybody needs to get to learn this basic skill, something like NG tube insertion or suturing or intubation, etc. So just with 4 or 5 mannequins, it won't be possible. I'll just take 2 minutes more. So this is the Indian scenario. So skill lab is just like a white elephant sitting there of no use. And keeping the cost, it's going above the ceiling. And this is the current perception of simulation. And taking the market, by 2030, it's going to be about $8 billion market in US itself. These are the certain low-cost simulation solutions that we have locally developed. These are suture pads, hand wash trainers, wound simulation. This is something that is not made in India. Ultrasound guided procedure that we have made in less than 500 rupees, and IUCD trainer. So right from the concept of high-end simulation, now we have come down to low-cost simulation lab, which could be made in just couple of lakh of rupees maybe. So it is changing, this concept is changing the landscape of how a simulation lab should be currently in a resource-limited setting like India. So also we have started Simicon, which is world's first dedicated low-cost simulation competition, because I wanted students to come up with the new novel ideas so that they can build for themselves to learn. So these are certain ideas from the competition, skill trainer for wound care, IV cannulation, etc. This is from the first competition. It's first of its kind initiative for low-cost sustainable solutions. It will transform medical education. And we are involving students from multidisciplinary team from engineering, doctors, medical nurses, and all the healthcare providers to pitch in and give the ideas. And this is how we are using the already existing low-cost simulation for evaluation purposes. This is this year's simulation competition, and it was under the aegis of the University of Health in Chhattisgarh. This is a picture from the same. And this is some of the novel ideas. Somebody has developed visual field. This you won't find anywhere. This is a very novel. This type of ideas are quite novel. These are not commercially available or otherwise. And this is something like a simulation for cesarean section, laparoscopic trainer. So I'll leave you all with some of the research questions that I believe during COVID, some of the patients were requiring more than 5 liters of oxygen. As you know, I mean, you will be knowing probably that this is a small oxygen concentrators. So each oxygen concentrator can give about 5 liters of air. So suppose somebody is requiring 8 liters, so it won't be possible with just one. So we required something like this type of device. So I was thinking, can we have something like an online database where I can put, okay, I need so-and-so device, and that I can have probably like a small 3D printer in my hospital. And can that printer print that type of T-shaped device? So can we have similarly for simulation, can that printer print an anatomical model to teach my students? Or if I'm doing a procedure, can that printer print something like a stent or a prosthesis? Similarly, for planning for surgery, if I'm performing a very complicated surgery, can that be done with a low-cost 3D printer? So these are some of the things that I found that are that could be used in future. Can we have something like a Google Lens that can be used in periphery to check ECGs, to check maternal movements or fetal movements, or to see the chest X-ray? So just finishing about one of the big corporations are greedy also, and this EpiPen is required for some of the people who are very allergic. So this is a epinephrine pen, and this is the cost of epinephrine pen, which gone from 9,000 rupees to 40,000 rupees. So a rise in more than 400%. So some low-cost solution has to be devised for such important issues. So India is going to be global leader in healthcare in future, and let's make it accessible and available and affordable to all. So will the solutions that we make help these people? Thank you. With that question, I want to end.
Thank you, sir, for this informative and thought-provoking presentation. Now I invite Dr. Amit Raj, Manager Director, Plexus Med Care, and Mr. Rahul Sethi, expert and founder of Metaverse 911, for delivering their presentation. I'm expecting this to be a very exciting one.
Oh, great.
You have this, you can control and change it from here. Yeah, this is the slider, and there is a pointer with this as well.
Please. Thank you, Sachin. Always, every year we come out with some new innovation. So, keeping Plexus long-term mission of digital health, since 3-4 years I've been doing on last mile cardiology, reaching out to the rural villages where cardiology is not available. Having a cardiac doctor, cardiologist available at a small hut using digital applications is something very innovative. And I'm proud to say that more than 1,000 patients we have really seen on acute MIs, and we could treat them, at a very early stage. Like Dr. John mentioned in his initial thoughts, what happens when a patient has been diagnosed with any medical problem? Who takes it to the hospital nearest? Well, it's the ambulance drivers. Well, I mean, it's the reality. Kickbacks are to be paid to the ambulance drivers to funnel the patient to respective hospitals. You know what happens there? The patient gets in a dilemma of what to do. He's been diagnosed with a heart attack or a stroke or a acute fever or a trauma. Patient really doesn't know. So the decision maker is the ambulance driver, who is a non-medico, and the medico over there, they are not trained. They are just trained paramedics who can only shift the patient from the house to the ambulance, and likewise. So how do we cut this gap? So we had thought about this, and I'm proud to say that connecting my rural village is now, with the help of trying to break the shackle. Companies like LIC and State Bank have collaborated with us in near future, in the coming few months, where we create a connected care 5G ambulances, especially for cardiology solutions. For example, an acute MI. What happens from a village where my clinic is there, in a hut, patient is diagnosed with a heart attack, ST is elevated, we give the primary medicines over there. The logistics and how they are connected to the command center at our hospital is something which I'm working at this stage. And with this reimagining healthcare delivery with technology was very exciting when Sachin informed us about this topic to be discussed. We were in the verge of adding another domain in our digital health ecosystem, that is AR, VR, and MR into our system, and the upcoming blockchain in the near future. So we have come out with an amazing solution where we can, post-COVID rather, I mean, everybody had a bad experiences with themselves or with their kins or with their relatives, that how hospitals and how the dark phase of life really changed the entire ecosystem. So we felt this AR, VR, MR would definitely bridge this gap, bring in more transparency to what we've been talking about. So in few minutes, we would be, talking about how this is going to be changing the the confidence building within our patient, and the patient is getting empowered, and keeping patient centricity as our focus, we wanted to take it forward. I'd like to introduce Rahul Bhai. Rahul Bhai is a metaverse, he's a genius. I mean, we just met online, and physically we met, we shared our ideas, and we thought, let's create something which is really going to be really disruptive. He liked my thoughts, and I love his thoughts. And we both finally, we thought, let's make a collaborative effort where we jointly make a system which will definitely bring in that overall experience to the doctor and as well as to the patient per se. So, keeping that as our objective for today's topic, reimagining healthcare delivery with immersive tech, let's take it forward. Rahul, how about, the use cases? I mean, if you can see, engaging a patient in holographic patient consultation, then remote expert consultation, and training simulators. Can you just put a thought on it?
Thank you. Thank you very much, and I'm very delighted and privileged to be here. Thank you very much to InnoHEALTH team for inviting us. There are the immersive technology also called as extended reality. I like to give you a little bit of a simplified version of it. If I had to say to you 15 years or 20 years back that you will one day drive a car that won't need a fuel, won't have an engine, also won't have a driver, you would have thought, okay, what is he talking? Similarly, in the next 10 years, you would hardly use mobile phones.